In this session, we are going to learn about a very common respiratory presentation in the pediatric age group that happens as a complaint of noisy breathing. So, have you ever come across a baby who landed up suddenly in pediatric emergency and the mother says that the baby is barking like a dog? So, yes, this is basically an abnormal sound that is produced from the vocal cords, and it all happens because of post-inflammatory changes. So, a noisy breathing scientifically is known as a stridor. So when does a stridor happen in pediatrics and what are the common causes behind it? So what is stridor basically? Now stridor is a harsh and a high-pitched musical sound that is produced by the turbulent airflow through the partially obstructive airway. So if this is a trachea, it is generally protected by the epiglottis. So whenever this airway gets obstructed and the air is to be pushed very forcefully inside or outside at the time of expiration, it can produce an abnormal sound. So that sound is generally very harsh because it is very forceful and a turbulent flow. It is very high pitched and it could be a musical sound as well. So these kind of abnormal sounds that is produced due to a partially obstructed airway, which is due to inflammation, so that is known as basically a stridor. It could be inspiratory, expiratory, or biphasic depending on the respiratory cycle. So, at the time of inspiration, there could be abnormal voice production. At the time of expiration, also, there could be abnormal voice production, or even in both the phases. So, depending on what is the level of obstruction or where is the lesion that is actually present, it can result into various presentations. Inspiratory stridor, which is mostly going to happen when the child is inhaling inside. So that is always caused because of extrathoracic lesions. Now, if this is the airway of the baby, these are the lungs, and this is the trachea dividing into two parts. So if there is any kind of extrathoracic lesion, that means there is some kind of compression happening from outside. So if this is the rib cage that is protecting this airway, if there is any space occupying lesion in the outside, that is extrathoracic infection, extrathoracic mass, any kind of tumor which is compressing the airway. So once the airway gets compressed, if the airway is compressed or narrowed, then what will happen? The air that is trying to pass through it will have a turbulent flow, because if this is the passage and it gets constricted over here, so this area is going to have a very turbulent flow. So because of this turbulence, this harsh voice is produced. So that is known as inspiratory stridor. And vice versa, if there is an expiratory stridor, that means once the baby has inhaled everything and is trying to exhale it out, then it produces an abnormal sound. So that usually happens because of intrathoracic lesions. So when intrathoracic lesion is there, it will try to obstruct the passage of the air when it is getting exhaled out. So this is the exact pathophysiology that happens behind the onset of stridor. So if it is inspiratory, it is because of extrathoracic lesion. If it is expiratory, it is because of intrathoracic lesion. So it is very simple to remember. It's vice versa or crisscross. That means I is going to happen because of E and E is going to happen because of I. So that way also you can easily remember, and if you know the concept, it is much more easy to remember it. So moving on to the causes of stridor. Now basically whenever there is inspiratory stridor, it is always because of partial supraglottic airway obstruction. So when the main airway is lightly obstructed, the supraglottic part that is above the vocal cord, if that gets obstructed, the air that is coming inside will not move freely. So other aerodigestive tract symptoms which the baby can develop is having a suprasternal and intercostal chest retractions. So because the airway is not very patent, it is going to get obstructed. The movement is also affected, producing a stridor. The baby can also have distress. So that will manifest in terms of chest retractions. There could be feeding difficulties and a muffled cry also. If it is a biphasic stridor, that means in both the phases we are hearing the sound, even in the inspiration and expiration. So it is caused because of partial obstruction at the level of glottis. So when at the level of glottis there is obstruction, it will cause disturbances in the inspiratory phase also and in the expiratory phase also. And in cases of expiratory stridor, if the partial obstruction is at the level of subglottis. So once we pass below the vocal cord, if at that level we are having some kind of external obstruction, or just proximal to the trachea, it will produce an expiratory stridor. Other symptoms which the baby is going to have is a xiphoid retraction, barking cough, and nasal flaring. So, barking cough is basically because just above the trachea and the subglottic part, the vocal cords can get inflamed. So, because of this post-inflammatory changes, the voice changes, resulting into a barking type of cough. So, these are all the classical presentations and the basic etiology or pathogenesis behind the onset of stridor. So, it could be inspiratory, biphasic, or it could be expiratory. Now, the approach towards stridor should always be that we should know the cause. Till the time we don't know the cause of stridor, we cannot treat it. So, it's very important to take a good history. What was the age of the onset of stridor? That means, is it since birth or is it acute? So, many times there are some congenital anomalies which can present into stridor. So, if they are going to cause the obstruction of the airway, it can present like stridor. Or if there is some outside source of like foreign body or something like that, it can also present as stridor. So what is the age of onset is very, very important, whether it is congenital or an acquired cause. What is the duration of stridor? Is it just the acute onset or it is present for a very long duration of time? Severity of stridor, that means is the noise produced in all the positions when the baby is sitting, lying down, prone, supine. So that shows that there is no change with the change in the voice with the change in the position. So that is a very important point. We'll see further why it is important. What is the progression of symptoms? So whether it is mildly symptomatic, whether it is very, very severe. What is the precipitating event? Maybe when the child is feeding, then only we can hear the abnormal sound. Or when the child is crying, then we can hear the abnormal sound. Then the positioning of the child is also very important. That means whether it is in supine position or prone position. So quality of nature and the nature of crying. So many a times the voice gets affected, so it can be permanent. That means the space occupying lesion is so pronounced that it is going to cause obstructive symptoms in all the phases. So even when the baby is crying or trying to talk out something, at that time also there is some kind of abnormal voice production. Perinatal history is very important, whether the mother was infected with maternal condylomata, whether there was any endotracheal intubation that was done for the baby which has resulted to damage of the vocal cords. Presence of congenital anomalies, the feeding history of the baby, whether the baby is able to feed properly or whether there is coughing and choking because of some abnormality or obstruction, the growth history and developmental history. So growth and development is important. Why? Because if the baby is neurologically compromised, then there can also be stridor many a times because of disorganization in the swallow and swallowing reflex. That means the coordination that is present while swallowing and while breathing. So that in coordination can also result into abnormal noise production. So the history is very, very important so that we can arrive at the diagnosis. That is what is the underlying cause behind this onset of stridor. Then examination again can help us take very much clues from the what is the exact presentation. So what could be the cause behind the onset of stridor? So we have to examine the heart rate, the respiratory rate, because that will tell us how much is the respiratory distress. The onset of cyanosis, which will show whether the distress is so bad that the oxygen level has decreased to an extent that it can result into cyanosis. Use of accessory muscles of respiration. This again shows us the onset of respiratory distress. So how severe is the stridor? Nasal flaring, again to say how severe is the stridor, that means how much respiratory distress is happening. Level of consciousness and responsiveness. So if there is decrease in the oxygen acutely, it can result into decreased level of consciousness. Drooling from the mouth. So if the baby is toxic, that means the inflammation in the airway is so much that even secretion of the saliva is not possible. It is so painful. So in those conditions, the saliva might drool out from the mouth. So it indicates that it is definitely some kind of inflammatory cause that has happened, which is resulting into stridor and this toxic appearance of the baby. Dysphagia, again difficulty in swallowing. Character of the cough, cry and voice. So whether it is high pitched or low pitched, that is very, very important. Careful auscultation of the chest so that we can auscultate and appreciate the abnormal sound, that is stridor. So examination of the basically respiratory system, the cardiovascular system and the local area, that is very important to know what is the etiology behind the onset of stridor. So coming to the etiology, so what can actually cause stridor? Now there are many causes which can result into stridor, but it is important to understand the concept behind it again. So stridor is basically caused when there is obstruction of the airway. So it can happen in two ways. If there is something which is already present, which is space occupying lesion that is causing obstruction of the airway and has decreased its caliber, or when there is some acute insult which can result into inflammatory changes. So when the inflammation is happening, again it can result result into abnormal noise production. So these are the two broad concepts that we should know so that we don't forget the common causes. So the common causes which actually produce stridor are, so in acute onset of stridor, something known as laryngotracheobronchitis can happen. Now, acute onset means the baby is well and suddenly develops stridor. So when somebody develops a stridor suddenly, it is an acute infection that has happened. So most common infection that produces stridor is croup, also known as laryngotracheobronchitis. This is the most common cause of acute stridor in children. It classically presents in the preschool age group, but it can start as early as 6 months and it can progress till 2 years of age. Now the child presents like a barking cough. So it coughs, the cough is like the character of a dog. So it is like a barking cough. This happens because of the inflammation of the airway and also because of the vocal cords. So this is a very characteristic presentation in croup. And it can also have a low-grade fever. So these are all the important characteristic features of croup or laryngotracheobronchitis. Now, another important cause of this acute onset could be sudden ingestion or accidental ingestion of a foreign body. So, aspiration of a foreign body can happen in children who are from 3 to 4 years of age. So, an apparently well child, if the mother says that child was absolutely well, he was playing with his siblings and friends, and suddenly after that developed this noisy breathing. So, most likely it is a foreign body. So, while playing maybe with peanuts or maybe with other kind of pieces of paper or any kind of part of the pen or toy, if the kids are playing and accidentally they play catch or something and they throw the particle onto the friend's mouth and he tries to catch it and accidentally it goes inside the airway. So that is how the accidental ingestion of the foreign body happens. So in this case, if the child is going to aspirate the foreign body, the most common age of presentation is when the group play happens, that is around 4 years of age. Food items like nuts, popcorn and candy, like we play catch and we throw the popcorn and the candy into each other's mouth. So that can result into aspiration of foreign body. So the mother will always give a history that the baby has started to cough and choke suddenly and the stridor or noisy breathing is present. Otherwise, the child would be absolutely normal. That is why he was playing with his friends. So this foreign body history is very important. So two important causes from here, croup and foreign body. Moving ahead, the next cause could be bacterial tracheitis. So as the name suggests, tracheitis is inflammation of the trachea. Now it is not very common, but sometimes in children younger than 3 years of age, they could have certain viral or bacterial infection which can result into overall inflammation of trachea. So if the trachea is inflamed, again it has become less calibrated. That means the caliber of the airway is less. So whatever air is flowing through it will get a turbulent flow, producing this noise known as stridor. So secondary infection with staph aureus following a viral infection can also result into tracheitis. So most commonly it is post-viral infection which is caused due to superadded bacterial infections. Now, another cause could be a retropharyngeal abscess. So, any space occupying thing which is growing and enlarging day by day and has got compression of the airway. So, once the airway gets compressed, it can present with stridor. So, if there is a retropharyngeal abscess which happens as a complication of bacterial pharyngitis, it is usually seen in children younger like 6 years of age. So, around 4 to 5 years of age, they can have this infection. There's an abrupt onset of high-grade fever followed by difficulty in swallowing. Why? Because it's a space-occupying lesion. If this is the abscess, which is growing and enlarging, this is our airway, so it can compress it. So once it is going to compress, what will happen? It will present with difficulty in breathing or abnormal noise production, that is stridor. It can also go on to compress the esophagus, so that will produce difficulty in swallowing, known as dysphagia. Refusal to feed and an onset of sore throat. Hyperextension of the neck. Now, to relieve the symptoms, the child will automatically hyperextend the neck so that the obstruction is relieved. And respiratory distress, definitely, because the airway is obstructed. So, these are the characteristic features of retropharyngeal abscess. Then the child could also have a peritonsillar abscess. So infection in the potential space between the superior constrictal muscles and the tonsils. So when the tonsils get inflamed, the area in and around can get infected. So this space which is present in and around the tonsils, if that is infected, it can cause a peritonsillar abscess. It is common in adolescents and pre-adolescent age group also. The patient develops severe throat pain and trouble in swallowing and speaking. So again, it is an inflammation that has happened, so that can cause airway obstruction and also difficulty in speaking and swallowing. Then also the child could develop something known as spasmodic croup or acute spasmodic laryngitis. So again, the inflammation of the larynx. It is commonly seen in the age group of 1 to 3 years of age. Presentation could be very identical to croup, but it is caused exclusively due to laryngeal inflammation. So larynx inflammation, trachea inflammation, all of these can result into post-inflammatory obstruction of the airway. So anything which is occupying the space causing decreased caliber of the airway can cause the onset of stridor. Now there could be allergic reactions. So whenever there is anaphylactic reactions, again it can result into reactive inflammation of the airway. So hoarseness and inspiratory stridor can be present. There could be dysphagia, nasal congestion, itching of the eyes, sneezing, and wheezing. So anaphylactic reactions in the body. For example, if the baby is allergic to peanuts and accidentally eats the peanuts, what will happen after some time? Histamine and other reactive markers are released in the body, which can result into this kind of episode of sneezing and wheezing, and the airway gets inflamed. So at that particular time, it will produce a noisy breathing known as stridor. Then also very commonly seen epiglottitis. Now epiglottitis is a very toxic condition. It is a medical emergency instead, because it can cause almost very close obstruction of the airway. So the epiglottis, which is actually the protective cover present in just front of the trachea, if that is only inflamed, what will happen? It can cause a sudden shutdown of the airway, which can result into very high severity of the airway obstruction. So most commonly seen in children from the age of 2 to 7 years. Clinically, the patient experiences an abrupt onset of high-grade fever, sore throat, dysphagia, and drooling of the saliva. Now, the baby will not be able to swallow the saliva also. It is that severe. The obstruction is so huge that there is so much difficulty in even swallowing the saliva. So, it will result into drooling out of the saliva with high-grade fever. So, this is classically known as a toxic presentation. So, this toxicity is classical for epiglottitis. So, we have to give a stat dose of dexamethasone or steroid so that we can decrease the inflammation of the epiglottis and the airway obstruction is relieved. Now, there are certain causes of chronic stridor. So these were the acute onset of stridor. That means something which has happened just now, any kind of infection which has presented into stridor. But many a times the mothers come with the complaint that the baby is having abnormal voice production or abnormal noisy breathing since birth. So chronic stridor means basically the duration. When we discussed the history part, it was very important to ask the duration, the positioning of the onset of noisy breathing. So that helps us to realize whether it is present for a very long duration of time, whether it is a chronic condition or not. So chronic stridor can be present in congenital anomalies, which is present even since birth, and it can result into the abnormal voice production, abnormal cry because of the airway obstruction. So laryngomalacia is one of the most common causes of inspiratory stridor. So laryngomalacia, it is basically the weakening of the larynx, and it can also have certain other associated anomalies like any space occupying lesion like a web or something like that. So basically, if the weakening of the muscles has happened, that means the larynx is not strong enough, it is weak. So that can also produce inspiratory stridor in the neonatal period and early infancy. It accounts for as high as 75% cases of stridor. Now, very classical feature that is associated with laryngomalacia is that when we keep the baby in a prone position, the stridor is improved or it might even be absent. However, when we keep the baby in a supine position or when we feed the baby or when the baby is crying, then this noisy breathing is definitely present. So stridor may be exacerbated by an episode of crying or feeding, and placing the baby in a prone position with the head up improves the stridor. So that is because of the positional change that has happened. So this is very classical for laryngomalacia. Instead, on clinical examination, we can diagnose laryngomalacia if this kind of presentation is there. Supine position can worsen the stridor, whereas prone position can absolutely improve the stridor. Usually begins and is self-limited till the child reaches the age of 1 year. So laryngomalacia is a very common congenital anomaly that produces stridor only in infancy. That means by 1 year of age, if the baby also had this kind of laryngomalacia, it gets to resolve on its own by age of 1 year. So spontaneous resolution is seen in most of the cases. Now, there could be subglottic stenosis. So, another common cause for chronic onset of stridor is subglottic stenosis. So, if there is automatically the stenosis is present because of some congenital cause or because of post-intubation, so it can result into subglottic stenosis. It could be inspiratory or biphasic stridor both. It can be congenital or acquired. So, in congenital, there is incomplete canalization of the subglottic and the cricoid rings, Whereas in acquired, it can happen because of prolonged intubation. So if the baby is mechanically ventilated for some cause, it can result into stenosis of the subglottic part. So if that part is stenosed, again a turbulent airflow will happen, which will produce abnormal sound known as stridor. So this could be another cause of chronic onset of stridor. Now, another cause could be a vocal cord dysfunction. Now, vocal cords are very important to produce the noise or the voice in a person. So, if the vocal cord is only not normal, then what will happen? It will produce stridor or abnormal sounds. So, it could be a unilateral vocal cord palsy. It could be a bilateral vocal cord palsy, or usually a complication of common CNS abnormalities like Arnold-Chiari malformations or increased intracranial pressure. So what happens basically in unilateral or a bilateral vocal cord palsy? So if it is a paralysis, then the vocal cords will not move normally. So vocal cords are present like a V-shaped structure. So if it is a unilateral paralysis, it could be congenital or secondary to trauma at the time of birth or at the time of any kind of surgery. So if the nerve supply to the vocal cord is cut down or the nerve supply is affected because of any surgical intervention or because of any trauma, then one of the vocal cords might not move normally. So if it is not moving normally, it can produce noisy breathing as well. Whereas in bilateral vocal cord paralysis, it presents with aphonia and a high-pitched stridor which may progress to severe respiratory distress. Now, if the both vocal cords are not moving, it is stiff like this, then what will happen? It is not moving at all. So, if it is not dynamic, the air that is trying to pass through it will not be able to pass at any stage. So, chronically, it will produce a constant high-pitched noisy breathing that can result into severe respiratory distress as well because the air is not able to pass freely. So, unilateral is little less severe, whereas bilateral could be very severe. So vocal cord dysfunction again can present with stridor. Now, apart from these, certain other common causes which can be seen, any kind of congenital lesions like laryngeal dyskinesia, laryngeal web and cysts, which could again be a space occupying lesion leading to airway obstruction. Laryngeal hemangiomas again could be a space occupying thing. Laryngeal papillomas can again cause the disruption because it is going to occupy the space right on the vocal cords and the larynx might not have a good caliber for the airway flow. Tracheomalacia, that is weakening of the trachea, again can produce abnormal sounds. Tracheal stenosis secondary to extrinsic compression. So if there is anything which is compressing the trachea from outside, maybe a lymph node or maybe any tumor or mass, then again it can produce noisy breathing. So anything which is actually just obstructing the airway, the concept is that whenever the airway is not having a good caliber, that means it is obstructed either because of inflammation, either because of any tumor, mass, lymph node or any kind of vocal cord problem. So it can result into abnormal voice production and noisy breathing that is known as stridor. So how do we manage a case of stridor? So most important is to relieve the obstruction. So the airway maintenance is very important. If the obstruction is very severe, then we have to give the respiratory support to the baby. So maintaining the airway, the positioning of the body and the neck is very important. At certain positions, maybe the stridor is improved. So we should try to keep the baby in that particular position. Supplemental oxygen if required because of severe RD and hypoxia. Stridor has got varied etiology. Therefore, the most important step in management is to know what is the cause and to treat the cause for stridor. So summary for this topic. Now, stridor is very important because it can be a medical emergency at times. It is basically a harsh, high-pitched noise that is produced at the time of respiration. It is mainly caused because of airway obstruction. So whenever the airway is obstructed, it can produce this high-pitched noise. It can be inspiratory, expiratory or biphasic. It needs a very good etiological workup so that we can know the cause and we can treat the cause behind the onset of stridor. The causes could be congenital and acquired, and the management depends on treating the underlying cause. So till the time we don't know the cause, whether it is acquired, congenital, acute, chronic, we cannot do much to improve the baby. So it's very important to work up the cases of stridor to know that what is the exact cause behind it so that we can treat stridor and relieve the airway obstruction.